Good evening. We're just waiting for the last few people to join us. So we'll just hang on. I can see there's some people coming through the waiting room. Thank you very much. So my name is Louise Halfpenny. I'm the Director of Communications for West Herts Hospitals NHS Trust. Thank you very much for joining us this evening. And the purpose of tonight's session is to give you a little bit more detail on our women's and children's services. And we're talking to you as part of our public engagement on Your Care, Your Views. So tonight we will mute your microphones and ask you to keep your cameras off, which will help with the bandwidth. You will see that some of our panel members are on camera and they will introduce themselves when they speak later on. We hope you will send us questions as we go through the session, and please use the chat function to do that and send them to West Herts Communications. If I have 2 or 3 questions the same, I'll paraphrase them and put them together. So if you don't hear your question asked in exactly the words in which you sent it, that's why it may be that great minds think alike and somebody else might want to ask the same question. We are recording this session and it will be available on our YouTube channel soon. So the aim of the session is to explain the proposals that we have developed to deliver new services across our 3 hospitals. And tonight particularly, we want to give you some additional insight into the proposals for women's and children's services. We want to tell you how we're going to communicate with you and keep you engaged during our period of public engagement. And we want to give you lots of opportunity to ask questions. So a little bit of background. I have seen some familiar names out there, so I am sorry because I know you've heard this before, but there are new faces with us also. So to bring you up to speed, it's good for you to know that this is, well, we feel the closest that we've ever been to securing significant amounts of public funding to make some really big improvements across our 3 hospitals. We've been working for some time now on this with our commissioners, Herts Valley's Clinical Commissioning Group. And we want funding for our hospitals in Watford, that's Watford General, Hemel Hempstead Hospital and St Albans City Hospital. In 2019, Prime Minister Boris Johnson visited the site and gave us the good news that we were going to be one of the 6 trusts on the National Health Infrastructure Plan. So if you ever hear us talking about HIP or HIP1, that's because HIP1 is the first wave of the Health Infrastructure Plan. There's new language now being used, and that is the New Hospital Programme, and the front runners have now number 8. So there are 8 front runners in the New Hospital Programme, and that's just a bit of jargon for you, but we will try not to use too much jargon tonight. So it was great to hear the Prime Minister stand up and talk about the money, but it's not quite as easy as that. We are currently going through an outline business case, and as part of that, we have to really prove our credentials. We have to make a great case on terms of value for money and also benefit to patients. And as well as that, we have to show that not only is our scheme affordable, but it can be delivered by 2025 or soon after. So although we stand by the quality of our care, we would not be quite so pleased about the state of our buildings. And if you visited any of our 3 sites, particularly Watford, where the overall standard of accommodation and buildings is really pretty poor, you will know that we really do need investment as soon as possible. So Your Care, Your Views is not something that's been dreamt up by managers. It is a series of proposals that have had a lot of clinical input. Even during some of the darker days of the pandemic, we have been absolutely bowled over by the amount of time and enthusiasm that our doctors and senior nursing staff and service managers have put into creating the proposals that we're talking to you about tonight. We call it Your Care, Your Views. That's very similar to an engagement programme some years ago called Your Care, Your Future. And we reference it in our title because it has some of the same guiding principles about care closer to home, moving towards preventative health care, and really thinking more carefully about our sites. It's really important that you share your views with us as we go through this programme of public engagement, and there are a number of ways to do that. There is a survey on our website, and we'll also be flashing up the QR code at the end of the presentation if you want to access it that way. And there are a range of documents, so depending how much you want to research, you can read the strategic document, so our clinical strategy. You can see how that translates into the clinical brief, which is the most detailed document of our suite of 4 documents there. And there are also 2 engagement documents, one summary document, so one slightly shorter than the other. And also films like tonight's session are also on our website. So lots of information there for you to get your teeth into. There is a phrase that we use when we talk about our 3 hospitals. We say three's company, and I know that the normal comment is that 2's company and 3's a crowd, but we think our 3 hospitals actually are good company for each other. It's a really good network of hospitals that provide different services, and we want to emphasise that more as part of our proposals. So each hospital will have its own unique purpose. We've been doing that a little bit to date, but in many ways our services have just kind of grown at our hospitals without perhaps enough thought about how they work together. So our broad outline for our 3 hospitals is for Watford General to continue to be the site for emergency, specialist and complex care. St Albans City Hospital to be the site for planned surgical care, planned cancer care and an urgent care service. You'll know perhaps that the minor injuries unit at St Albans is currently closed, and we are looking at what model we will have at St Albans in the future. So there will be an urgent care service there. And at Hemel Hempstead, we will have urgent and planned medical care and care for people with long-term conditions. So we want to consolidate, not duplicate. And over the years, as I was saying, our services have really grown over our 3 hospitals, and sometimes that has been to the detriment of the quality of the services because we're stretching our clinical teams across all 3 sites. And that can lead to cancellations if there aren't enough staff to cover particular clinics, should there be some unforeseen absence. And it also means that our clinicians don't really have the full experience of working together in larger teams. So as part of our fresh thinking, now that we know that investment is hopefully on its way, we are really thinking about how to get the best use out of some pretty expensive diagnostic equipment and how to make working life better and more rewarding for our teams, and importantly, how to streamline our services so that we are not moving patients between many of or all 3 of our hospitals as they go through their treatment. So really trying to provide as many aspects of a patient's care under one roof as we can. And that may mean that your local hospital is not always the best hospital for you to go to. So if you live in Hemel Hempstead, but you need planned surgery, you will be seen in St Albans. And if you live in St Albans, but you have a long-term condition, the best place for you to be seen is going to be Hemel Hempstead Hospital. So there will be, underpinning this, a huge digital transformation. It is already starting. We are moving towards an electronic patient record, and we are also embracing online technology. So the kind of platforms that we're using tonight to talk to you, we are also using with our patients for online consultations. And our feedback so far has been overwhelmingly positive. So we hope that this is a model that we will continue into the future. It was incredibly useful during COVID, but it is something that we are going to keep doing because we know that our patients prefer it in many cases, and it makes our teams very efficient, and that means that we can easily see more people, and that in future people will wait less time to be seen. And we will also be upgrading our diagnostics, and in some cases purchasing new diagnostic equipment, and that will help us provide our treatment on a one-stop clinic basis. So if we can bolt on some diagnostics with a rapid result, and then make sure that you are seen within the same appointment by a consultant or a clinical nurse specialist, and then maybe you can think about planning your care or even begin your first treatment. So really looking to put as many steps of your treatment together in one appointment, and having brilliant diagnostics will really underpin that. So I am now going to hand over to, is it Deepan? Are you going to go first? And to introduce tonight's discussion. Thank you.
I will go first, Louise.
Thank you, William.
My name is William Forsen. I'm a consultant obstetrician gynecologist and also the divisional director overseeing women and children services. And I must say, myself and the team are very excited about the prospect of having this new redevelopment and to be in a position where we can continue to deliver high quality care, but also in an environment where both staff and patients would like to come to. If I just take you through the various aspects of the service, so I'll cover the women's services and then my colleague will talk about the children's services. So currently for gynecology service, at the Watford General Site, we have the outpatient clinics, diagnostic services, early pregnancy, day assessment, ambulatory care, inpatient, as well as elective and emergency surgery. And this would include cancer surgery at the moment. And then over in St. Albans, we are still doing clinics. We run an outpatient diagnostic center for hysteroscopy, urodynamics, and also carry out some surgery there. And then we do run a community gynae service clinic in Hemel as well. Once we provide this large range of services, we are constrained by the current buildings and the estate we have, and hence our excitement and delight that come hopefully 5 years time or so, we would have a brand new shiny building in the Watford site, especially to continue to provide this high quality care. The problems are well documented. The space, the clinic rooms are small, lifts break down quite frequently, and it makes working a bit challenging and for patients coming into our service. And particularly during the pandemic, this has been quite challenging for women and children accessing and having their families with them when they come to see us. So our future plans is to be in a position where we use a combination of tools. Louise mentioned the digital transformation. We are looking at where we'll be able to provide high quality care without patients having to make journeys and travel to the hospital by using virtual consultation. And in this new project, we are hoping to be able to enhance that program. We are looking to be able to provide a dedicated gynecology area where women with gynecological problems can come to one area on the Watford site where we'll be able to provide a one-stop facility for them. Currently, with the fragmentation and the lack of estate, gynecology services are spread all over the site in Watford, and it makes it a bit difficult sometimes to deliver the type of care we want. And in the inpatient area, we are hoping that we will be able to have everything on one floor, on one ward, and when women turn up, we'll be able to provide the diagnostics, provide treatment in a quick turnaround way so that they can go back to the community or go back home. So when we've done that for gynecology, we are hoping we'll be able to do the same thing for maternity or for obstetrics. So this looking at care for women before they become pregnant and care for women when they've become pregnant. And on the Watford side, we want to continue to be able to provide antenatal clinics, provide ultrasound scan, the midwifery care, triage, assessment area, birthing center, which will be led by midwives, provide antenatal and postnatal wards, operating theaters, and the neonatal unit. This will be unit where newborn babies needing additional care and support will be provided. We will continue to provide antenatal care and clinics in St. Albans Hospital, and we'll do the same thing in Hemel. So for obstetrics, our model is that we will continue to provide antenatal clinics across all 3 hospital sites, but the rest of the care looking at the pregnancy will be concentrated on the Watford site, where we will be able to provide the wide range of care and services for pregnant women and their babies. Again, obstetrics, we are constrained by space, and particularly on our labor ward, space is very tight. As the complexity of pregnancy has increased, we've had limited opportunity to expand our estate to accommodate this. And once again, in the pandemic, it's become particularly challenging, where we know pregnant women and to some extent, children coming to hospital, having family around them is something that is hugely beneficial, and we have been a bit constrained by that. So what we are excited about is having a new building or having a building where we'll be able to provide a room where women coming in or expectant moms coming with their birth partners will be able to stay in a room, have their baby, have the postnatal care, recover, and go home from there. And in these rooms, we are hoping the rooms will be well equipped to support the presence of birth partners and other family members to support them through these important but sometimes difficult times. We want to have a delivery suite with the latest facilities and equipment to be able to deliver this care in Watford and make sure that women coming in will be able to have what they need. The neonatal unit we mentioned, again, is one area where we are constrained at the moment. And again, having parents stay with their newborn babies sometimes when they need help and support can be challenging. And we are excited by the prospect of having a new neonatal unit with facilities to allow parents and new expectant parents to visit and to be able to stay for long periods and be with their children as we provide care. I'll pass on to my colleague, Deepan, to introduce himself and talk you through briefly about the rest of the children's services.
Hello there. So my name is Deepan Vyas. I'm one of the consultant pediatricians, and quite proud to be involved with all this new redevelopment work that's going to transform the way that we sort of really deliver care sort of for children across the region. And if I was to sort of start by explaining where we are currently and what we are sort of looking into. At the moment, we have children's services across Watford General Hospital, and they're also provided at Hemel Hempstead. Over at the Watford site, we have a wide range of outpatient clinics, both in general pediatrics, and we also have really developed sort of a wide range of subspecialty pediatrics so that we are able to provide high quality care for children very close to where they live. And and those sort of services are also expanded to Hempstead as well, so where we run a wide range of outpatient clinics as well. In terms of sort of more immediate and emergency services, we have a bespoke emergency department and a children's emergency department, which is quite adjacent to our pediatric assessment unit, which is a model of care that we're very keen to further develop sort of into the future, and particularly with the new build. We have a range of services that currently provide children on the Safari Day Case Unit, and this ranges from children who need to have elective or planned operations for certain conditions, who come in and have day case work done, as well as a range of other treatments and other investigations for which they need to come. And then adjacent to that, we have our inpatient ward, which currently is a 20-bedded ward with 2 high dependency beds, which are beds essentially designed for children who are more unwell, and where they require closer observation and perhaps more intensive treatment. And as William has already spoken about the neonatal unit, I won't go into that, but suffice to say that that is definitely in our plans to also develop neonatal services as well. Next slide, please. So, I mean, I think as William and Louise said, essentially the building that we work from has been a big point of constraint, and the way that services have developed since the building was built, it just means that we need to now start really thinking about adjacencies and also the building infrastructure, and this is a really great opportunity for us to be able to do that. There are currently a number of issues, particularly within pediatrics, and a lot of them really pertain to space. And there are sort of our outpatient area doesn't have a waiting area that's big enough, and particularly in light of the number of services that now we offer. Our pediatric assessment unit is smaller than we want it to be, because we really want to develop a model of care where the pediatric assessment unit actually forms the hallmark of the emergency patients that come in. And there are an insufficient number of cubicles, whether that's on the pediatric assessment unit or whether it's on our inpatient ward. And we want to sort of use the opportunity for the new build to really address some of these issues. But it also gives us a great opportunity to provide really important rooms, such as the breastfeeding facilities in outpatient services, so that we can actually make for a much more bespoke environment that is catered for sort of children and their parents. Next slide, please. So if we were to talk a little bit about the outpatient models that we're trying to develop, again, this has really given us a sort of a good opportunity to work on the building, but also work out different and improved models of care. And part of that is using the electronic transformation work that's being done to ensure that we can actually provide virtual consultations where it's appropriate. And we want to be able to provide face-to-face across both sites, at Watford and at Hemel. And one of the things that we're very passionate about is to have children's services remain largely in children-friendly environments, so that the right staff can look after these children, but also that the walls are and the environment is very children-friendly, so that it's much less traumatic and much less stressful when these children come into hospital. And equally, in the inpatient side of things, we're really developing our pediatric assessment unit model of care, and we plan to locate that next to the emergency department, so that actually children can move quickly across to the relevant sort of areas that they need to get their investigations done much more quickly and appropriate, sort of much more quickly, and get those senior decisions made in a timely fashion. And to help with that, we were going to set up some hot clinics and other models of care that will really work to improve that patient experience. I think one of the issues that we've definitely had in pediatrics is we haven't had enough single rooms, and I think this is something that's been quite integral to in the new build, that we will have a much larger number of purpose-designed single rooms with facilities for parents and carers to stay in, which will make for a much less stressful stay for those children that unfortunately need to be admitted. And you know, and again, as it will all sort of be encompassed in that sort of pediatric area, we hope that it'll be a sort of much more bespoke environment for patients and their carers.
Thank you. Gosh, what a lot there was to learn from William and Deepan there. So really, really interesting. And I think we got your excitement, William. So thank you for bringing that to us on a Friday night. Here is the slide of the engagement plan. So you can see what's keeping me and my colleagues busy at the moment. We're trying to get as much information out to you as possible. We're trying to reach different groups in the community. So if you are a member of a group or a society and you want us to come and make a presentation to you, please get in touch. There'll be an email address at the end, and also all the contact details are on our website. So our first period of public engagement lasts until the 24th of March. We will then consider what we've heard, what the results are of our survey, and then we will go back out for a second period of engagement. During that time, we might wish to run some focus groups with our staff. We may need to clarify anything if we're getting lots of similar questions and it becomes clear that we've confused people or that we haven't been clear enough. We will provide further information, and then we will, after the second period of public engagement, provide feedback to the trust board, and they will use that to finalise the clinical brief, and that is part of our outline business case. So your feedback is important, your feedback even on just individual sessions like this, but really your feedback about our proposals. If you understand what our rationale is, why it is that we are so committed to keeping our 3-site configuration and how we think that can benefit our patients, then please say that you understand it if you do, or if you understand it but you don't agree with it, that's fine too. We really want a range of opinions from all the communities that we serve. Our survey, which I mentioned, is going to be independently analysed, so we won't have anything to do with that until the results come to us. So that's being done by a separate organisation. You can see the details of the survey there, and we can also translate. So we have some social media going out in different languages next week, but we will translate on demand, and we are also giving a presentation in British Sign Language next week. So please do keep checking our website, and I have got some questions, brilliant, quite a few. So I hope Deepan, William, you're ready for this. And then I also want, well, actually I'd like to start by bringing Fran into the conversation. So Fran will introduce herself, and I wanted to ask a question to Fran about a hotline that I understand was launched this week, and maybe Fran, you can use that as a really good way of explaining the different methods we have of people getting hospital services, which are increasingly online or over the phone. So over to you, Fran.
Sure. So hello, my name is Fran Gerkler. I'm the Director of Integrated Care here at West Herts Hospitals. So just briefly, just following on from what Louise was saying, we have the end of this week just launched a Pediatric Hotline. So this is just one of a suite of alternative ways of being able to access care without patients needing to physically be with us. So the opportunity here with the hotline is more so for GPs to be able to get immediate access to a paediatrician, to be able to discuss concerns around a patient, get the advice that may allow them to be able to be managed either in the surgery or over the phone, however that patient was presenting, and to try and help avoid an unplanned attendance, or possibly a referral in the first place. Where of course that is required, that will still happen, but this is an opportunity around being able to get rapid advice and guidance to support patients in a different way. This has formed part of a number of plans that we've got with different services, so not just the ones that we're discussing this evening, but it's happening in a number of our other work areas. And we found it really beneficial, and patients have definitely found it really beneficial in terms of being able to get advice quickly, but also more importantly to avoid needing to come onto a site at all. This is also complemented by some of the other work that is happening in terms of virtual appointments, so whether that be through the use of video or telephone consultations, where clinically appropriate, but also patients being able to initiate their own follow-ups rather than those quite traditional ways of working, whereby often we say to you, this is when we would like you to come in, and it might actually not be when you're having symptoms or when you've actually got concerns, and this moves the control back to our patients, which is exactly where it needs to be. So this is part of a journey that we're on at the moment. As I say, the hotline for paediatrics just launched. We're testing it in one of our localities with a view to rolling it out in the next month to all 4 areas within Herts Valleys. So it's a positive development, and is part of a number of different initiatives we've got. Some of this has come as a result of COVID. So it's our learning, the things that we adapted really quickly, and areas that we want to continue to build and develop on, because actually they've been the right thing to do for patients.
Thank you, Fran. Sorry, I was just looking at my phone because a question came in, but I thought it was a question that was better for our Chief Information Officer. So so I've managed through my simple technology to get an answer to one of the questions. So this is a question about electronic, the patient electronic system. So not particular to children's and women's, but will affect children's and women's in the same way as it affects all services. So the questioner has asked, what patient electronic system will you use, and will it allow interaction with tertiary hospitals, because it can be frustrating when staff have to chase results from other hospitals. So in answer to that, our Chief Information Officer says that we will be using Cerner, so that's the brand, and we call it EPR, Electronic Patient Record, and we are building a shared care record across our integrated care system. I told you there'd be jargon. So, so that means that yes, we can have a system where we can read patient information, and other trusts can also read our records with patients' permission. That's always at the heart of sharing data. So the answer is yes, we are getting towards a shared record where if you were to come into our A&E, but you were just visiting the area and you lived somewhere else, we would be able to see some of your data. And if you had needed a diagnostic test, which was not able to be provided at this trust, we would be able to look up your results. So yes, we are definitely moving ahead on that front. I have a question for you, Deepan, which is hot clinics. So could you describe hot clinics and the part they play in avoiding admission, and can you reassure us please that these aren't just clinics where we turn the heating up?
Yeah, so the new build has given us a really good opportunity to look at what we're doing and whether there's other ways we can be doing something just in a better way. And so actually it's been really great because we've had a lot of pediatricians who've just heavily been involved with reshaping the way we do things. And what we know is very much like Fran said about the hotline, where actually if you're a primary care the GP, and you just need a little bit of advice to just sort out the patient in front of you, we want you to be able to have access to somebody who can give you that piece of information or that bit of advice that can sort of prevent you needing to refer that patient in and have a long wait and then potentially come into a clinic. Equally, what we want is to have a model of care such that not everybody needs to necessarily go and sit in an A&E queue waiting for their number to come up before they're necessarily seen. So what we thought would be a really effective way of doing it is that if those patients who have actually gone to see the GP and the GP says, well, actually, look, you don't need to go to A&E right now, but actually, I don't want you to wait a number of weeks. We have a sort of set of clinics that will look at hot stuff, hot being sort of more acute stuff, or certainly stuff that needs to be seen more quickly in certain set clinics. And they will have a discussion with the consultant, or they'll make a referral to the consultant, and they will be seen within our pediatric assessment unit, which will be kitted out to see such patients and have those appropriate diagnostics done on that day, but in a more controlled setting, so that these patients don't necessarily go into the children's emergency department queue and essentially either end up waiting and causing a delay, not only for themselves, but for everybody. So those clinics, we're really looking forward to having that ability to see those patients in a sort of designated space, in a designated setting, by a senior consultant, or by a senior physician.
Thank you, Deepan, thank you. I'm going to come to you in a moment, William, but Fran, can I just go back about the hotline? And the question is, don't GPs just phone in anyway? So how does the hotline differ?
So this is about them being able to get immediate access. So I would have thought as a GP, it's probably nothing's more frustrating than needing to go through the switchboard, then to be able to speak to somebody. So this gives direct access into a paediatrician who will be able to then sort things directly. We'll also have an email address for that as well, for things that are less urgent that GPs want to be able to follow up. But it's more, we found it within other of our adult services that the GPs have really valued that ability to be able to speak directly to the expert and to be able to get that direct input.
Thank you, Fran.
Louise, just to add to that, whilst GPs can phone in, this would have a consultant scheduled and sort of almost at the end of the line waiting for the calls to come in. So it would be a planned activity rather than trying to phone around and see if somebody is available.
Excellent, yes, because our consultants aren't just generally waiting for a phone call, are they? So that explains why it is why creating a planned a special period of, we call them PAs, don't we, periods of activity or planned activity, where a consultant is there and is readily available, and that really can make all the difference between somebody coming in unnecessarily, perhaps in an ambulance, or it can just give that advice and guidance and reassurance that really can make all the difference. So sticking with you, William, I have a question around recruitment, and especially thinking that once we've got this lovely building, that we might have more women coming to us to have their babies, because we know a lot of women come to us for a large part of the antenatal treatment and support, but they don't always choose us for the labour. So when we've got our beautiful new building, we might see a change. And so the questioner wants to know how we will manage with recruiting midwives if we have an uptick in numbers of women wanting to have their babies with us. So I just wanted to ask you if you have any concerns about recruitment. I think at that very moment, William is frozen. It doesn't look like we've got William with us at the moment, so that's okay. I shall go on to another question, and this is about single room occupancy. So Deepan, we were hearing about single rooms, and it's certainly the way that we're going to go with adults. Does that create any difficulty in terms, it's again a staffing related question, does that create any difficulty in terms of needing additional staffing if children are in single rooms rather than on wards?
Yeah, no, Louise, that's an excellent question, and absolutely it does. And I think that in that question, I think it's a really important point that this is not just about a building that we're building, but actually this is about a new sort of a way of a model of care, essentially. And actually that involves workforce management and making sure that all the right bits are in the right place in the building, but actually we also have the right staff there to be able to look after them. And actually, you know, I've been working with a number of people on the redevelopment team to look at what the best way of actually putting those adjacencies are, so that, for example, you know, we're very keen to develop our HDU model, which is the high dependency care beds that we've got, and we want to make sure that they are placed in a way that they do have access to all the necessary equipment that they need, but they're also put in a way that we can actually staff appropriately. And one of the work streams that we're doing alongside all of this work is actually also looking at the workforce that will be able to work in this new building of ours. And so I think that's a great question, but absolutely, it goes hand in hand with the new build, and we're really looking at the expertise as well as the number that we will need to have the new build working well.
Thank you, Deepan.
Sorry, I dropped off.
That's all right, William.
I don't know what happened to the internet. Yes.
I didn't think it was that difficult question, really. I'm sure you can answer it. And
no, I didn't run away.
So I'll just rephrase a little bit, but it's a similar question to one that Deepan just answered, and it's about recruitment. If we want to have more women who stick with us right until labour, which we obviously would like that to happen, will you have enough midwives to look after them?
Yeah, so I mean, as I said, the whole new environment, the new ways of working will drive improve the recruitment for us. But linked to that is also the fact that in trying to design these new clinical pathways and trying to align our services to the way we want to work, it would mean that we can maximize the staff we have in providing the care by having the care more planned in a more concentrated area. So I talked about having a room where a woman comes in with a partner, providing support for them. They have their baby, they can be there, we look after them, and they go home from there. So there will be some improvement in redesigning the services, but I think that redesign of the service and the care we are providing and the building and so on is a magnet for recruitment, and other areas have seen that not just by having more patients, but having staff who want to work. I mean, staff have done incredibly well. They've stuck with our 30, 40-year-old building. And I'm sure as we have a new building, there is excitement, and we are looking forward to being able to recruit. Having said that, I mean, even now, with our way of working and our supportive environment, we are still able to attract staff and retain staff. So I have no doubt that as we look towards the future, we will be able to do this even better.
Thank you. And that makes me think about the session that we had on Wednesday with Tracy Carter, our chief nurse, and she was saying that really recruitment it's definitely not something that keeps her awake at night. We've got a good pipeline of nurses waiting to join us, and we have had a 0% vacancy in our Band 5 nurses, and not so long ago we were the UK Best Employer of the Year. So I think, you know, of many things that you can say about this organisation, and particularly the buildings, recruitment is actually one of our stronger points. So that's good. That's good to hear that also goes across maternity as well. Deepan, I wanted to ask you a question. You mentioned HDU, and I have a question here about HDU during winter, when we know that children can be affected by respiratory conditions and a whole range of other illnesses which make admissions much higher. are you planning a system that will flex and have surge for winter months?
So the short answer is yes. Yes. Let me elaborate. So winter surges are definitely something that we have got foremost on our mind. So we know that actually, the way that sort of children present in the winter are very different to the conditions that we see, particularly over the warmer summer months. And actually, one of the great advantages of having a largely cubicle-based ward will mean that actually we're able to sort of admit children into cubicles, which will mean that actually those children who are coughing and sneezing will essentially be coughing and sneezing in a much more localized space, so that actually, we can keep sort of patients separated from each other and keep them safe from one another. So that's our first mitigation against that. The second mitigation is that we're wanting to increase our HDU capacity, actually. So and alongside just like I mentioned, the buildings, we're also training up nursing staff, and actually we have specialized consultants who are really developing those HDU models of care so that we can look after a larger number of patients with these kind of illnesses, and mainly respiratory illnesses over the winter months. And then the third thing is the ability to surge. You're absolutely right. So, we look after a number of children with cancer as well. And actually what we know is that we want to be able to flex certain rooms depending on our need at that moment in time. So for example, if we get a lot of HDU patients or respiratory patients, then we want to be able to have rooms that we can flex into those very easily. And so absolutely, we have looked into that, and that forms a very important part of our HDU model going forward.
Thank you. And you mentioned cubicles, and there is a question on cubicles. So is there any additional risk factor from having children in cubicles in terms of raising the alarm and just generally observation?
Yeah, so invariably, if people are sort of in isolated cubicles without very close monitoring, then yes. However, along with just these cubicle care, first of all, we will be looking at safe staffing and staffing models that can actually support the way that we nurse in cubicles, but also, with the digital transformation program, we want to be able to have an ability to be able to look in on certain patients in terms of their observations and things from a central nursing base, so to speak. So we will have other parameters or other ways of actually making sure that these patients remain safe, and that will be monitored by the nursing staff from a central point. So that's very much that integration of the new technology with also the build to make sure that those patients remain safe in those buildings, in the new cubicles.
Thank you,
Louise, so to add to that, we are mentioning digital transformation, and it's not just the electronic patient records. We are looking at remote monitoring, wireless monitoring. So the blood pressure machines and so on will be in the room, but as Deepan said, can be seen and viewed, these monitors across the floor, to make sure you are keeping an eye on the children, even in the cubicles, without necessarily being in the room with them.
Thank you. And the system that William mentions is also something that we're considering for adult inpatient care. So we envisage that on the outside of a cubicle, there would be a panel, and that would have all the observations, and there would be alarms that would go off if as Deepan was explaining also, if the signals go outside a particular parameter. So there are, with the advent of technology, different ways to monitor our patients. I wanted to ask you a question that's come through about best practice and what we've learned from other hospitals. So I know we've been doing quite a lot with the Royal Free on the CPGs, which is the clinical pathway groups. Fran's an expert on this also. So I think maybe Fran, if we can come to you, if you can think of a CPG that's relevant to women's and children's services, and then Deepan and William, if they have anything to add. Thank you.
Sure. So I'm literally just going to introduce them because I think the clinical detail will come from our clinical colleagues. So actually within the women's and children's services, we've got 3 key areas that we're working on. So early pregnancy, wheezy child, and induction of labour. And we recently did a board presentation with some of the really positive outcomes that we've seen for women under the early pregnancy and the induction of labour, both in terms of reduced time for women in the hospital and being able to spend more time at home, and for wheezy child in terms of how they receive emergency care. Perhaps Louise, we could share a couple of those slides, not now, but if people would like to see them, we can put them on to whatever reciprocal we have to be able to put this. It was part of a board presentation that we did last month around CPGs as an overall, but there's some specific ones that we'd obviously pulled out for women's and children. So it might be useful to include them back on those for people that didn't have the opportunity to be part of the board presentations.
Sure. So we can definitely do that, and maybe Deepan, if you want to talk about wheezy child briefly, and then William, maybe some of the work around early pregnancy, because when we talk about working with the Royal Free, that is a lot of that is around standardisation and reducing unwarranted variation in care. But people better qualified than I will talk about that. And I have to say, it's not just learning from other hospitals. So some of the work that we've done, other hospitals are learning from us. So it's really a two-way street, and it's been very gratifying to see improvements in other hospitals come from some of the methodology that we've initiated here. But Deepan,
women's and children's actually is a really good example. So the ones that we just talked about, those women's and children's ones are absolutely ones that have been led really strongly from a West Herts perspective, and then have been adopted in other areas. So it's all good for women everywhere, but it gives obviously a greater pool of people to be able to work with as well.
Thank you, Fran. So Deepan, did you want to just spend a couple of moments talking about the wheezy child, and then we'll come to you, William? Thank you.
Yeah, so thank you. So ultimately, what we are very keen on doing is developing pathways, like you said, safe pathways for when when patients come in with common conditions, and if you've ever been around a children's ward, you know that wheeze is one of the commonest sounds that you hear. And actually, what we want to make sure is that children are getting safe care, they're getting appropriate care quickly, and actually it's in a standardized fashion, so that actually whether you come in on a Monday or whether you're coming on a Saturday, actually you get the same things happen in a very structured way, so that you can get better quickly and you can get discharged home appropriately. And we've been working very closely with our colleagues at the Royal Free and to develop a pathway such that that all of these set number of things will happen to ensure that not only are you getting the appropriate care quickly, but also we're putting a lot of other things into place so that actually it prevents you coming back into hospital. So along with getting that care that you would in the emergency department, and then subsequently getting the care that you would on the ward if you needed it, it also involves all that other stuff, such as the patient education, the parent education, making sure that they have all the right equipment at home when they get discharged, and essentially having a list of checklists and parameters that we want to make sure have been achieved in order to make sure that this child A, gets better quickly, but also B, this asthma attack doesn't happen again and they don't end up coming back into hospital. And the pathways just form a nice structured approach to doing that. And I think working with an organization such as the Royal Free, as Fran said, is great, because we can learn about things that they're doing well, and actually they can learn from us about things that we're doing well. And actually, and the converse is also true, in that actually if there are better ways of working, we can learn from each other and improve care for the majority of children,
Thank you. And I know, William, you've joined us fairly recently, so a lot of this work was ongoing, but have you got any other models that we're learning from?
Yeah, so I think West Herts, we do pride ourselves as being clinically led, in other words, sort of bringing clinical decision making into how we design our services and designing our building. I think clinicians have been very much being the focus of trying to think about how we want to work in the future and design a building around that. And in doing that, we have had to review the best evidence available and the best models of care out there to try and bring all that together. So we've mentioned early pregnancy, we've mentioned induction of labor. We are trying devices to allow women to start that journey in trying to have their baby from home, in the comfort of their home, but also feel supported at home and to come to hospital, spend the minimum amount of time in hospital, have their baby safely and go home. And there is good evidence that if we can do that, we would reduce the levels of interventions, cesarean section rates, and so on. So we have thought about these processes in designing our rooms and our buildings. And when I talked about having a room that is multi-purpose, so that the traditional way where you started your induction of labor in one room, you had a baby in another room and go to another room for your postnatal care, we've given way to that by just designing one room where we are able to accommodate all these aspects of having a baby, and induction of labor starting from home is a key part of it. Early pregnancy is largely an outpatient service. We have designed our building to have it next to our ward and ambulatory and gynae assessment areas, such that for 24/7, women can come, we can give them advice, we can scan them, we can support some of the emotional challenges and difficulties sometimes that happens in and around sort of early pregnancy problems and so on. So we have thought about what's good for our patients by looking at the evidence and feeding that into how our building will be designed for the future.
Thank you, William. And Fran, I've got a question that's got your name all over it, because the question is, it says, what you describe means a much stronger interaction with the community trust. How is this being managed? So I think our Director of Integrated Care is definitely the right person for this question. Over to you.
So it is absolutely, at the moment we're doing some co-design work, so bringing together both patients and then all of the different stakeholders into how we are developing these pathways. So obviously for something like Wheezy Child, so for the Wheeze pathway that we've talked about, intrinsic to that is both primary care colleagues and our community teams, and we have a joint working group that's happening at the moment. We are about to have a business case which will see joint posts brought together. So from a patient perspective, it shouldn't really matter who is the provider of your care, whether it's West Herts Hospitals or HCT, who provide the community paediatric service. As a service user, you just need to receive the care that you require at the right time in the right place. And that's the whole aim of where we're going at the moment. As part of the work that's happening for the Wheeze pathway, though, we have just also launched the patient co-design piece. So this is an opportunity whereby patients, for patients within paediatrics, is both the children and obviously their parents or carers to be involved in the design of the pathway work as well. So those details are out there already. We have an engagement group that we already work through, and they help us then to source patients for us to be able to work with to both give them ideas, but more importantly for patients who are best placed to manage this, to say what is important to them, what works for them and what doesn't as well.
Thank you, Fran. Well, we are just at the end of the questions. I have had a compliment come in about all the impressive plans. So good to hear so many impressive plans is one comment. And I agree. It really has been a very uplifting session. Like I said earlier, the excitement is, well, it's coming off all of you. So let's bring on that new building as soon as we can. I'd like to take a moment to remind you to complete the survey and to find out more about women's and children's services, but across all of the areas of our of the services we provide. There's lots of information about plans that have come from our clinicians getting their heads together, looking at the best evidence, thinking into the future, and trying to do what we say we want to do, which is the very best care for every patient every day. So please read the information, do the survey if you have time, and come back to us for other sessions all next week. At 6 o'clock, we'll be running sessions, so we hope you can join us. And I really must thank you for being with us, but particularly to Fran, to Deepan, and to William for giving us such a rich evening full of information. So thank you to you all, and stay safe, everyone. Good night.